I
We
think
are
we have
live
got the
now.
permission for Dr. Sachin for recording the session.
Yes, please.
Yes, thank you.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Low Ovarian Reserve, organized by Fertility Obstetrics Gynecology Continuing Education Society, Chennai, and also A4 Hospitals and Fertility Center, Chennai. So it's my privilege to introduce the moderators of today's webinar, Dr. Aruna Ashok ma'am. Ma'am is the fertility consultant, clinical director at A4 Hospital, and ma'am has more than 17 years of experience and also mentor for fellowships, reproductive medicine, A4 Fertility Center from 2022 onwards, faculty of FNB Reproductive Medicine, executive committee member of TAPISAR and OXY. I welcome you, ma'am.
Yes.
And it's my privilege to introduce the other moderator, Dr. Rini. Ma'am is currently the fertility consultant at A4 Hospitals and Fertility Center, Velsheri, fertility consultant at Nova IVF Fertility, MRC Nagar and OMR. Ma'am has more than 7+ years of experience in reproductive medicine. I welcome you, ma'am, and I hand over the session to moderators.
Thank you.
Can you show Dr. Sachin's CV?
Sure, ma'am.
So I think everybody here will know him. He is obstetrician, gynecologist, lab surgeon, and IVF specialist. His affiliations are to Madhu Hospital, Banduk, Embryon IVF, Vikroli, Fortis Hospital, Jupiter Hospital, Surya Hospital, won various awards at Mog's conferences, and a very interactive person. When he presents, the audience cannot take the eyes from the presentation. I have been listening to his talk. So over to you for your thoughts and practice points on low ovarian reserve. So I think Dr. Rini will make it more interesting and more proactive. At the end of the session, we'll have lots of questions and discussions, I hope. Over to you, sir.
Perfect. Thank you, Dr. Aruna, first for inviting me for this very prestigious webinar. And second, for introducing me. I like to keep my introduction short and sweet without wasting much time. So I would like to now present the slides. Just a moment. All right. Is the slide seen?
Yeah, now we are able to see.
Yeah, perfect. Okay, and the slideshow is happening, right?
Yes, yes.
Perfect, great. Yeah, so I'll just start off. I'll just adjust it here. Yes, okay, fine. So this is all good. Fine. So, hello friends. I'm Dr. Sachin Dalal from Mumbai. Today we are going to speak on a very important and a very bothersome topic which affects all of us, be it fertility consultants, be it regular obstetrician and gynecologists, and this is something what we call as the poor ovarian reserve or low ovarian reserve. And why are we so much concerned about it? Because as we are seeing over the last few years, the age at marriage and the age at which the women are actually coming to us for seeking fertility, that is increasing. Initially, the girls would get married by the age of 25 to 27. Now we are seeing average age of marriage around 30, 32. And as we all know, there is a natural decline after 35 years of age. And in certain subset of patients, especially women who are suffering from endometriosis or who have undergone previous ovarian surgeries, there can be an accelerated follicular atresia. Also to keep in mind, genetic factors like Turner syndrome, fragile X premutation, and familial early menopause. So there are families where menopause runs in families. A lot of women will give you an history that my mother or my mother's sister or my elder sister, she got menopause at the age of 40, 45. So that is something that we need to ask in our history and keep in mind. Autoimmune disorders, especially autoimmune nephritis, thyroiditis, Addison's disease, iatrogenic causes. Now, this is very common these days. You have a lot of patients who have had a simple ovarian cyst. they land up with a specialist, and majority of this you'll find are surgeons. And the surgeons, they will not wait for the periods to come and do a recheck whether the cyst, a simple cyst, has gone away. And this poor girl, be it a simple ovarian cyst or be it a hemorrhagic cyst, she'll undergo a surgery. And we have a histopath report which says the same. Ideally, in such girls, only thing that was needed was probably progesterone in the luteal phase. Wait for the periods to come, repeat the scan after the periods, and in majority of the girls, we find that the simple ovarian cysts, or for that matter, even hemorrhagic cysts, have disappeared. Chemotherapy and radiotherapy, this we are seeing so much rise of chemo and radiotherapy, especially in young people nowadays. Pelvic infections, as lifestyle changes, as more of our people get influenced by social media, we are finding early initiation into sexual intercourse, into sexual activity, thereby having pelvic infections, PIDs, also multiple sexual partners. That is the reason we are also seeing increase in the rise of recurrent infections, PIDs, UTIs. So this is something that we need to educate our girls about. Smoking again, very much on the rise, especially in women working in the corporate sector. Toxins, the plastic bottles. Nowadays, I think everybody of us has got used to drinking the 10 rupee wala filtered water or a Bisleri water, and these are containing a very high amount of BPA. And there have been loads of studies which show that exposure to BPA causes a reduction in the oocyte counts and causes a poor ovarian reserve. Severe stress or malnutrition can also be one of the factors which can cause a poor ovarian reserve, especially in young women. So, how do we define? Now, what happened is when the patients used to come to fertility specialists, they found that what is the definition that we look for? How do we define these girls? So, first, Eshrey came across in 2011 and let down the Polonia criteria, where they said that any two out of the three of the following we can label a woman to have a poor ovarian reserve. So, what are the criteria? First and most important, women more than 40 or having any other risk for poor ovarian reserve. And what all risks are we talking about? Any of these risks which can be one of the causes of poor ovarian reserve. There was a nice paper which was published. It was a joint Indian and a Spanish collaboration where they found that our Indian women have aging 6 years before the Western Caucasian counterparts. So, in this subset of women, here they have taken into account the Caucasian women. In our subset of women, I would probably not be labeling it as 40, but I would be more aware about the age of 35 in our women in our society. Also, second point would be a prior history of poor ovarian reserve, where she has undergone a conventional stimulation protocol with a full dose, not a low dose stimulation. And at the egg retrieval, only three or less than three oocytes were retrieved. And last but not the least, an abnormal ovarian biomarker, that is AFC less than 5 to 7 or an AMH less than 0.5 to 1.1. So we need to keep these factors in mind. Any girl having any two of the three criteria, we can label this women and poor ovarian reserve. And these are the particular women in our OPDs where we have to be extra cautious about, because these are the ones who are always going to cause a lot of heartaches. So there was a problem with the Bologna criteria, that it was a very generic. They just labeled women above the age of 40. And they found that, the previous cycle stimulation, a random cutoff was taken of less than three oocytes. And hence, it was not very individualized. So they came again and laid down the Poseidon criteria, which came out in 2016. And now all of us are following this Poseidon criteria for women with poor ovarian reserve undergoing IVF. Also, if any of these criteria are met, we need to alter our treatment strategies and see that we can reduce the time to pregnancy. Very simply, they divided the women into four groups. Group 1 and Group 3 were women who were young less than age 35. Group 2 and Group 4 were over the age of 35. So Group 1 and Group 3, young women. Group 2 and Group 4, elderly women. Also, Group 1 had normal AFCs and normal AMH. They subdivided this category of women into Group 1A, where there were less than four oocytes which were retrieved in the previous ovarian stimulation cycle, and 1B, where 4 to 9 oocytes were retrieved. Similarly, in Group 3, they found that AFC less than 5 and AMH less than 1.2, that is a young and a woman who is a poor ovarian reserve. In Group 2, same criteria as Group 1, AFC is more than equal to 5, AMH more than equal to 1.2. Similarly, 2A and 2B, 2A had less than 4 oocytes retrieved at previous OS cycles, and 2B had 4 to 9. Similarly, Group 4 were established poor ovarian reserves like Group 3, where they had less than 5 AFCs and less than 1.2 AMH. Now, how is this significant? This is what is the significance. Group 1, we know, are young and suboptimal, and these are the ones who will give us the surprise, where everything looked okay, but we have a low oocyte number retrieved. Group 2 are old, we can be aware, but again, this was unexpected. Group 3 and Group 4 are young and old respectively, and we are expecting a low oocyte number in this subset of women. In Group 1 and Group 3, there is a low embryo aneuploidy risk, while in Group 2 and Group 4, there is a high aneuploidy risk. So, in case of Group 2 and Group 4, if she has had history of previous abortions, you might also think of offering PGTA to this particular subset of women in Group 2 and Group 4. Now, looking at the incidence of POR, the data is all American data. They found it was 9 to 24% amongst patients undergoing ART. SART data showed that almost more than 50% of 14.1 cycles were cancelled due to POR. However, diminished ovarian reserve accounts for almost one-fourth of the IVF cycles, and in these women, 30% had poor ovarian reserve. So what pre-treatment? Now this girl has come to you, you've done your AMH, you've done a day 2, day 3, day 4 ultrasound, and you found that she is having a poor ovarian reserve or a low ovarian reserve. So how do we treat this woman? Now in this subset of women, I would recommend doing an early tubal patency, not more than 6 months. Usually we reserve it for more than 1 year of active married life. In these women, if for 6 months they have tried and she's not been able to conceive, do a tubal patency test either by a sonosalpingography or HSG. At our center, we prefer the HSG because of the obvious benefits. One, the report is stored very well, easy reproducibility. Anybody can review the reports. And most importantly, we've found in quite a lot of women that the dye that is used at HSG, it also acts as a flushing, and a lot of women have conceived spontaneously after the HSG as well. Give all of them combination of folic acid, DHEA, coenzyme Q10, and testosterone gel. I've forgotten to add vitamin D out here. We also give standard vitamin D supplementation for this women. And if the tubes are open, till the time this medicine action take place, let them have natural timed intercourse from the 10th day to 20th day of the cycle. Or you can also do a follicular monitoring for 2 to 3 cycles, because in our experience, we found it takes almost 2 to 3 months for the full effect of DHEA, coenzyme Q10, and testosterone gel to occur. I like to give them a natural micronized progesterone or dydrogesterone. If it's natural micronized progesterone, it will be 200 milligram SR OD or BD. Or if it's dydrogesterone, it will be 10 milligram BD from day 18 onwards. This is basically to give a luteal phase support. It also helps to regularize the cycles in case she's having delayed periods due to any reason. Also, we do a thorough evaluation of the male partners in this subset of women. In case the chap is more than 35 years of old, he's obese, smoker, alcoholic, Married since more than 5 years, consider DFI testing because we find in a lot of these men DFI to be more than 20 or 25, and these chaps also need to be treated to have a better pregnancy outcome. And obviously, lifestyle modifications, a healthy lifestyle, regular exercise, sleep on time, cut down the junk food, stop smoking, stop drinking, stop doing recreational drugs. And lot of these women, lot of these couples, you'll find their frequency of coitus is weird, once in a month, once in 15 days, So these are the girls where you'll have to tell them importance of regular timed intercourse and explain them about the ovulation cycle, that when the ovulation can occur. We also use LH detection kits for these women who cannot come down for follicular monitoring, or those girls who are having irregular cycles. That gives us a nice two lines suggesting that the ovulation will be occurring most likely in the next 24 to 48 hours, and that is the time when they have to be together. Also, looking at the rationale behind why we would be using this pre-treatment, DHEA supplementation, these are all paper summaries. It has found to significantly increase the number of oocytes retrieved after stimulation. However, number of M2 oocytes, clinical pregnancy rates, live birth rates, miscarriage rates were not materially affected with DHEA supplementation. So this is for IVF. But what have we seen in our patients who are not for IVF but for our regular timed intercourse or regular follicular monitoring cycles, or even for that matter IUI cycles? We have found that when we are giving DHEA to these girls for minimum 2 to 3 months before starting the treatment, or along with the treatment, there is a significant increase in the antral follicle count in almost 50 to 60% of the women. Similarly, testosterone supplementation, we have noted significant increase in the number of oocytes, clinical pregnancy rates, and live birth rates. However, no significant difference in number of M2 oocytes or miscarriage rates. Combination of DHE and testosterone we found to have an increase in the antral follicle count compared to those women where there was not given. Coenzyme Q10, very important. It is a fat-soluble antioxidant naturally present in all cells. As we all know, it plays a critical role in the mitochondrial energy production. It is basically a powerhouse. It's the fuel for the powerhouse. And as the age increases, the coenzyme Q10 levels always decrease, impacting the cellular energy and the egg health. It is known to enhance the mitochondrial function in the oocytes. It protects the eggs from oxidative stress damage. It helps in ATP production. It improves that. It is also essential for egg maturation and fertilization. And there are studies which are shown to help delay ovarian aging in especially women at with a poor ovarian reserve. So what is the evidence say? Evidence says that coenzyme Q10 supplementation has shown to improve the ovarian response in IVF cycles. Studies indicate improved fertilization and embryo quality, particularly beneficial in women over the age of 35 or with poor ovarian reserve. Most common dose is 200 to 600 milligrams of ubiquinone or ubiquinol form, and it is best taken with meals containing fat for better absorption. So give it post meals for all your patients. Now we have done timed intercourse cycles and she's not conceived after that. So what can be done? If it is a 33, 34-year-old with poor ovarian reserve, or 35 married since 2 or 3 years, these are the women who might not be willing for IVF despite everything. Or even if she is more than 5 years married and not wanting IVF, what you can do? It's not that these women don't conceive with IUI. So we found in our clinical practice that for women with POR, IUI can also be considered in this following patients, which are young women less than 33 years of age, married life is less than 5 years, and most importantly, the semen parameters should be normal. What we usually do is after 2 to 3 cycles of this has been tried, normal follicular studies with progesterone in the luteal phase. After 2 to 3 cycles, we do IUI if they are not willing for IVF. And our cutoff is AMH should be more than 1. If it's less than 1, ideally she should go for IVF. IUI up to 4 cycles can be tried, as we all know. 2 cycles can be tried with oral ovulations. Now, these are the women where my first choice of drug is clomiphene citrate. Why clomiphene citrate? Because it is known that clomiphene citrate is a multifollicular development. And trust me, when you use clomiphene citrate and you do your own follicular studies, you'll find that there is not much difference on the endometrial thickness. And a lot of women, especially women with POR, do conceive with clomiphene citrate. And my usual starting dose is 50 milligrams given from day 3 of the periods. And if there is no response with 50, then we give to go to 100. More than 100, I don't use. Similarly, for letrozole, I would give them letrozole 5 milligrams and not 2.5 milligrams. And in a lot of women, we've found letrozole giving multifollicular development with a dose of 5 milligram. We can also combine gonadotropins along with oral ovulogens. I prefer HMG in this subset of women. Also, a realistic success rate has to be given to this women, and usually we found that the success rates in IUI is around 10% in a women with POR. You've done your IUIs, you've done the follicular studies, and still this girl is not conceived. What next? Now these are the women where you have to consider and you have to do IVF. Now what we would do in IVF? First, don't use ultra high dosages because it is shown that high gonadotropin dose uh, significantly increase the number of oocytes, but limit it at 450. More than 450 HMG or more than 300 of ERIC FSH does not give you increased clinical pregnancy rates. So at our center, we don't increase dose of REC FSH more than 300, or if it is HMG, then more than 50, 450. GnRH agonist and GRH antagonist both have similar results. However, what we have found in our clinical practice that women with POR are the ones who have asynchronous growth of follicles during stimulation. So I prefer doing the GnRH agonist protocols because what we have found and a lot of other colleagues have also found is with GnRH agonist protocol, one, the follicular cohort synchronicity is better. And two, in my opinion, the number of follicles retrieved with GnRH agonist is slightly better than the GnRH antagonist cycle. And most importantly, these are women with poor ovarian reserve. If serum progesterone on the day of trigger is less than 1.5, we can definitely consider doing a fresh embryo transfer in this women. If you are using a GnRH antagonist cycle, it might be prudent to give her a pre-cycle treatment with estrogen from day 21 of the previous cycle. So I usually give estradiol hemihydrate, 2 milligram twice a day from day 21, continue it till day of menses. And once she gets a period, you stop. And there have been studies which have found that agonist and antagonist both have similar results. Letrozole or clomiphene citrate along with gonadotropins has been recommended to reduce the dosage of gonadotropins, but I don't follow that in our clinical practice. For IVF, I use gonadotropins alone. Also, GnRH agonist flare protocol is not recommended over the long agonist protocol. And now we have a lot of data which shows that a duostim protocol is not recommended over the standard GnRH antagonist protocol. So what we would do is we would first do a GnRH agonist protocol, get the oocytes. Usually we are able to get 1 or 2 embryos and do a fresh embryo transfer. If all the other parameters are well met, like a good endometrium, serum progesterone on the day of trigger is less than 1.5. And if I'm doing the GnRH antagonist protocol, then in that case, I always counsel the patients that you might have to do multiple cycles. And I don't really follow the duostim protocol. Now, types of gonadotropins. HMG or recombinant FSH are equally efficacious for ovarian stimulation. At our center, we use more of HMG, and for this, I would strongly recommend our colleagues, our group who are there on this webinar, to read a few papers. One is the MERIT trial, second is the MEGASET trial, and third is the MEGASET HR trial. And this you will find that HMG has a slight benefit over REC-FSH at a reduced cost for ovarian stimulation. If you've used REC-FSH, it can also be seen in especially poor ovarian reserve women that you've given for 5, 6, 7 days of rec FSH and the follicles have not grown. In such women, a mid-cycle addition of HMG, especially in long agonist cycles, is recommended if there is a poor response to rec FSH. Also, sometimes you found the same problem not only in the long agonist cycles, but also in the antagonist cycles. Urinary FSH over rec FSH is not recommended in poor responders, obviously due to a batch-to-batch variability. Recombinant FSH gives our standard response as expected. Increasing gonadotropins beyond the standard doses of rec FSH 150 or 225, maximum dose that we follow is 300, definitely not more than 300, is not recommended. Increased risk of gestational diabetes mellitus and maternal hypothyroidism is known on increasing the gonadotropin dose. Addition of rec LH, however, it is not available anymore, is recommended to rec FSH versus rec FSH alone. So to take care of this, it is simpler, more prudent, and more economical to use a HMG than use a rec FSH alone. And for all women, without exception, please use the dual trigger. That is a combination of agonist and HCG for oocyte triggering. So in App Center, for all patients, be it timed intercourse, be it IUI, or be it IVF, exception being hyperresponders, we follow a dual trigger, recombinant HCG or a HCG 10,000 with an agonist, either lupride or decapeptyl 0.1. If it is IVF, I will use a lupride 0.2 or a decapeptyl 0.2 with rec HCG for oocyte triggering. And why? Because HCG will only give you a LH surge, while agonist will first give a small FSH rise. This helps improve the M2 conversion of the oocytes, followed by the LH surge, which will cause the final maturity. And we have a lot of data now which shows that a dual trigger gives a better oocyte retrieval rate compared to a plain HCG trigger. Embryology and embryo transfer protocols. Follicular flushing at oocyte pickup is not recommended. So what is follicular flushing? You've done the oocyte pickup. Then there have been few studies which say that they would flush it with the oocyte media and do a repeat flushing, but found that it was just increasing the time of ovarian pickup with no increase in the oocyte yield. ICSI in absence of male factor is not recommended. I've spoken this multiple times on various fora that at our center also 80 to 90% of our cycles are IVF cycles. Only if there is a male factor infertility associated, then we go for ICSI. Otherwise, we don't follow ICSI for all. Similarly, freeze-all strategy is not recommended in poor responders. We just discussed about that. Again, most importantly, routine PGT is not recommended in poor responders unless she is more than 38 or 40 years of age or there is history of aneuploidy previously. And most importantly, this is something again that I've shared with our colleagues. PRP or stem cell for ovarian rejuvenation is not recommended. I've done it in my patients when there was a fad of doing a PRP. We've done for 5 to 7 patients and found absolutely zero response in increase of the antral follicle count or increase in the AMH levels of these women. So we've stopped doing the ovarian rejuvenation with either PRP or stem cells in our patients with poor ovarian reserve. So this is the final slide. What is my protocol for women with POR? I use DHEA, coenzyme Q10, and testosterone gel for all the women. If the AMH is less than 1, I use DHEA 75 milligrams BD. Coenzyme Q10 usual dose is 300 and testosterone gel I use OD. In case it is an IVF patient, I will use it BD. AMH less than 1, I prefer doing the short antagonist protocol with HMG with luteal estradiol pretreatment, as I just mentioned. If AMH is 1 to 2, I prefer doing the long agonist protocol with HMG 450. In my opinion, and also there is data, HMG gives better results than rec FSH plus rec LH combination in poor ovarian reserve women. We give dual trigger for all our women. Ovum pickup is done at 34 to 35 hours of trigger. No follicular flushing is done. We do IVF for all patients unless there is male factor coexisting, and we do fresh embryo transfer if serum progesterone is less than 1.5 on the day of trigger. Thank you so much.
Uh, Thank you so much, sir. Sir,
Yes, Dr. Jaya.
will you be? Can you take up the questions in the chat box, sir?
Yes, I'll do that.
How
I'll just see the
to
questions.
improve oocyte quality in low ovarian reserve?
I already mentioned
Yeah,
that.
you mentioned that. And do we need to give both DHEAs and testosterone gel?
I
So
do
that's
that
also.
because I have found that it is better
Okay. And how long do we give testosterone gel?
for
3 months.
2 to 3 months. 2 to 3 months.
Role of luteal phase stimulation. So you said
I don't do that.
don't do it. Will you use DHEA even if patient has a high testosterone levels and
Y-
low AMH?
Yes,
So
because
do,
we found that in this subset of women, even though she's having high testosterone levels, DHA definitely helps. So I usually give it for 2 to 3 months, and we see an increase in the antral follicle counts and response to stimulation after using DHA. And so many times, as I mentioned in my second slide, that we give a combination of DHA, coenzyme Q10, and testosterone gel. So many times women just conceive spontaneously while waiting for IUI or IVF.
okay, sir. Do you take the cutoff of P4 as 1.5 on the day of trigger, or does it vary according to the responders, sir?
So see, there are two schools of thought. One school of thought believes that use 2 for hyper responders,
Yeah,
1.5 for normal responders,
and
and
1.2.
1 for poor responders, or 1.2 for poor responders.
Yes.
But it causes a lot of confusion.
Okay.
So, and there are a lot of papers which have now shown that keeping a standard cutoff one of 1.5 can help. So I keep at our center 1.5 for all our patients.
We have few other questions, sir.
Sure.
Any role of
Uh,
melatonin combination in POR patients?
Yes, so I have one combination which is also using melatonin and is shown to have slight benefit. But if we look at data, we don't have much data. But so we have combinations available which gives melatonin along with that. Only thing that I found melatonin working is it gives good sleep. So I usually give melatonin to women at night around 8 or 9 o'clock, and they have a good night's sleep. So it helps improve their sleep cycles and makes them gives them a lot of relaxation. So there is another question that in low ovarian reserve day 4 follicle 13 by 12, and she ovulates at day 10 or day 11. So this is, see, what happens is any woman. Now let me just share one thing. Okay, so this will help people a lot. Um, I'm just sharing my screen again. Just give me a moment. So this is something which will help people a lot. Okay. Now, as we all know, this is you can see the screen?
Yes, sir.
Yeah, okay. So this is the standard 28 to 30-day cycle that we have in all our women, correct? Always the luteal phase is going to be fixed 14 days. Follicular phase is what is going to change. In a woman with PCO, the follicular phase is going to get widened. You'll have it 21 days, 30 days, or even 40 days. However, the luteal phase is always going to be 14 days. So if your patient is having ovulation on 11th day or 10th day, most likely she is having a 22 or a 24-day cycle. And she is going to have most likely a 24-day cycle. That is the reason why he's ovulating on the 10th day. So in this cases, what you have to do, now, uh, guys, I just need to be in a minute. Someone has something urgent has come. Just give me a moment. I'll come. Dr. Aruna, if you can just answer the questions on my behalf. I'll be there in 1 minute.
Sure, sir.
Yeah, Rennie? Yes.
There's newer drugs. Even today, madam was asking rapamycin and all these drugs for patients with low reserve.
Drugs like?
Resveratrol?
Resveratrol, glutathione, rapamycin.
Okay. I think we have not started using those drugs, but glutathione is antioxidant, so that is not to be worried about. Resveratrol, lots of controversial studies, but its use in endometriosis is well proven. For endometriosis, we have used for a good number of patients and had some relief. But for a low ovarian reserve, now this because of DHEA is banned to be given as 75 mg. It can only be given as a 25 mg, and the production has to start because in India we are now having only 75 mg dosage. So now, if you wanted to make it as 25 mg dosage, many of the companies are newly producing it. So the newer drugs are like a lot of antioxidants are being given shortly. Even some of the famous brands are modulated and changed. So this long-term efficacy we have to look upon. But DHEA and androgen supplements or gels are proven. Like for example, when the androgen pool is levels are improved, then the antral follicle count, the baseline antral follicle count is high. So it gets improved. We have seen it over the years. Though there are lots of there's no concrete evidence for its routine use. I think every other fertility consultant, when they have a AF antral follicle count less or AMH being low, we start using either DHEA or androgen gel. But some clinicians regularly use to all the both together also. But now we have got DHEA, the dosage is changed. It is 25 mg 3 times a day is only thing which is allowed. I think we have to get more formulations for us to use it routinely. The other one is I don't have rapamycin, no use. Anybody who's using it can let us know also. Yeah.
Ma'am,
Uh,
other questions? Can we take those questions up now?
Yeah, I think we can. So there are lots of questions now.
Yeah.
Yes. Yeah.
Question: the role of drugs like mTOR and EQOQ.
and that is also co-cure.
Yeah.
mTOR.
Doctor is back. You can ask him now.
Hi.
Yeah.
Yeah. So honestly, I have used EQOQ, but not much experience. And still, since my experience with DHEA testosterone is too long, almost 10 years, I still stick to DHEA, testosterone, and coenzyme Q10. mTOR, I have never used, so I have no idea. Role of growth hormone in POR. Yes, you can definitely use growth hormone in POR. There is definitely an
Not so
advantage. You
fast.
can,
Sorry to interrupt. See, now
yeah.
the DHEA, the new regulations is 25 mg 3 times a day. And are you getting 25 mg 3 times a day dosage? I think
So,
the whatever products we are having, you are using, but maybe we have to, or everybody should start using this 25 mg 3 times a day dosage. So how are you using now?
so as of now, I have old stock of 75 milligrams.
Okay.
But once the old stock gets over, we have no option but to use the 25 milligram TDS. But I'm sure, what happened with letrozole, that letrozole had a ban and pharma had stopped letrozole because of the DCGI instructions. Uh, this is going to come back because 25 milligrams 3 times a day becomes very inconvenient for the patients to use. And we've been using coenzyme DHEA 75 milligrams since years.
Yes.
Also, it is available 75 milligrams over the counter in United States markets as well as a health supplement. So I don't see the way I'm seeing is that 75 milligram most likely will make a comeback. They will just alter the composition, and most likely it has to come back.
Using androgen gel, what is the dosage that you're using? Because I find doctors using twice a day, once a day,
Yeah,
different formulations.
yeah. So for women, AMH less than 1, I use it twice a day. For
Okay.
women, AMH 1 to 2, I use it once a day. Again, women more than 60 kilos of weight, then I use it twice a day, because I've found that, uh, once a day sometimes does not give that kind of response like what it is given twice a day. And
Okay.
pre-IVF, I always make it twice a day, because we've actually found that when it is done twice a day, there is definitely increase in the antral follicle count. And as it is, as I mentioned, testosterone we will not be using for more than 3 to 4 months. So really does not make a huge difference overall to the patient.
Do you stop the DHEA and androgen gels while starting the stimulation, or you continue it till the pickup?
I continue it till the pick. I stop it at pick.
Sometimes do you find while using it, the follicles are slowly growing because you're using androgen gels? No.
No, 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 not really, not really.
Okay.
Nothing like that. Actually, there was a nice paper from Fertility Sterility,
Okay.
which showed that when you used DHEA, it helps in the decidualization of the endometrium, especially in women with poor ovarian reserve.
Okay.
So what they said is you continue in this subset of women till the time she becomes pregnant, and this is published in Fertility Sterility.
Good. Because many of the times, after IUI, for example, ovulation induction or IUI,
Yes,
they do stop all the medicines. So
right,
DHEA
right.
can be continued, but androgen gels we tend to stop after the ovulation and IUI, right?
Beg your pardon, could you just repeat?
After, for example, not a pickup, we are doing a IUI for a patient
Yeah,
who's
yeah. IUI, so usually I continue it. I don't stop it because then it becomes very confusing to the patient. So I usually continue it in women with IUI, and I just stop it when they are going to conceive. So the women are instructed that when you conceive, stop this immediately. So see, this is the paper that I was talking about. I'll just share it again. Okay, I'll just share my screen again. So this is a beautiful paper which was published in Fertility Study in 2018. It's seen. Are you able to see this?
yes.
Okay. So it was a university research institute, and you can just probably take down the PMID number and do a reading from your end. And what they found that desensitization responses, let us go to conclusion. These novel results demonstrate DHEA can enhance the in vitro desensitization responses of HESF from women of advanced reproductive age. Supplementation with DHEA during receptive phase may augment endometrial function and improve pregnancy rates in natural or assisted reproductive cycles. So this I had read a long time back, and since then, I started using it for all my patients, and
Fantastic.
really happy with the result.
Fantastic that you also showed the evidence, so everybody will be happy to use it. Nice.
Absolutely. So, usually whatever I say is going to be backed by evidence. So
Yes.
since this is a paper which I've shared on the groups multiple times, I had it handy. That's why I just showed it to you.
So nice. You can go to the next question, Dr.
Yeah,
Rini.
can we use DHEA during stimulation cycle IUI, IVF? Yes, I use DHEA 75 milligram OD or BD we just mentioned. If it is AMH less than 1, I prefer giving it BID. And luckily, I still have stock of 75 milligram. Once that gets over, we have no choice but to give 25 milligram TDS, or maximum QID. Madam, enlighten on progesterone monitoring on the day of trigger again. Dr. Aruna, you want to take this?
So there's a question in between. Role of growth hormone in POR patients during stimulation.
Yeah, I did answer that. That there is a definite role of growth hormone, and people use those of 2 to 4 international units. However, I have not used in my subset of women yet because I am using a lot of DHEA, coenzyme Q10, and testosterone gel. But after the recent Cochrane review, I am planning to use growth hormone in my patients, and probably after a year or so, maybe we can give a update. Dr. Aruna, any experience from your end with growth hormone?
We did a study with 25 patients comparing growth hormone, yes, and using and not using. We didn't find any difference. So, but for a patient who has already tried twice and they are doing a very precious cycle, then we do add growth hormone. But when I do add growth hormone, we check the growth hormone levels for the patient before, and I also do hemoglobin electrophoresis and skull X-ray, so that just that any patient who has some baseline screening is done and then we start it. I think this much we should do before starting growth hormone for a patient. Serum growth hormone levels, hemoglobin electrophoresis, and a skull X-ray, AP, and lateral view. Otherwise, there is no risk of starting growth hormone, but the costs need to be kept. We are not starting. Maybe if I do 100 stimulations, one or two patients gets a growth hormone. This is the number that
Okay.
we.
And why would you do HB electrophoresis? How does it help?
They tell that when there is a patient having sickle cell or a thalassemia, this growth hormone might aggravate the thrombosis event. This is what we had the publication. We did a study.
Okay, all right. Dr. Nidhi, please mute yourself.
Yeah.
Yeah. Okay.
Thrombosis incidents are higher, but not much of usage has been done by me. So when I did the study, we started with hemoglobin electrophoresis to rule out other conditions. So we started doing it, thalassemia and conditions.
Our senior colleague, Dr. Rajesh Korodia, has an extensive use of growth hormone, and he finds it definitely beneficial in subset of poor ovarian reserve. And I think, you can probably
Yeah.
think.
Which all patients you use growth hormone? Posidone 3 and 4?
I have never used yet,
Okay.
but yes, he has used for Poseidon 3 and 4.
We did a very small study with 25 patients, but when I used it, both the arms had the equal results. So I thought, okay, putting on another medicine to the patient was really harm.
Agree, agree,
So
agree,
that's how
agree.
we just stopped using it. But when there is a doctor couple who's coming and asking me, I want to start growth hormone, yes, we do start it. We don't tell them that I cannot do it. When the patient, nowadays, patients come and ask what I could start. So very rarely we are using it. Not
Okay.
routinely we are using it.
Okay, so Dr. Divya has asked what brand of DHA I'm using. So these are local Mumbai brands. There are two brands which I'm using, which gives me a combination of coenzyme Q10, DHEA, melatonin, and coenzyme Q10. Yes. So one is a brand called Ovario, other is a brand called DHEA Sure. And since almost a long time I'm using this, and I still have stock of that, so I'm using it till now. Once the stock gets depleted in the next 15-20 days, I'm not sure whether they will be, because the companies have told me that they are going to change the formulation according to the new DCGI guidelines. Androgen for 21 days or 3 months, I usually give it for 3 months, though the studies say 21 days, but in my opinion 21 days does not really work. Dr. Archana Sampath, when do you want to start? I think Dr. Aruna very well explained how it is usually started along with stimulation, never prior to stimulation. Ovulation on day 11, how to manage? So these are the women where the cycles are 24-day length. So it's okay. You start your follicular monitoring from day 6 and give the trigger and do a plant relations. No harm in that. Dr. Divya, okay, Suryama XT.
Aruna,
Yes.
Madam, enlight on P4 monitoring on the day of trigger again. Ma'am, are you aware?
Yeah, that question. See, we are doing the study on why I think somebody would have seen our reports taking P4 on the day of trigger. Unless we do a fresh embryo transfer, monitoring P4 doesn't have any role while doing a stimulation cycle. If the P4 is more than 1.5, then we do all free cycle, and less than 1.5, we do fresh embryo transfer. This was the initial days that we were doing. Now that many patients are asking for frozen, and our cycles also is 90% frozen embryo transfers, why we are doing P4 is to analyze the results of high P4 and oocyte quality. We are doing a study. Based on that, we started doing this and we are yet to conclude it. But as such, with the progesterone only pill and progesterone primed ovarian stimulation being coming up, I think doing a P4 and assessing the oocyte quality has become null. There is no problem because patients are being put on meprate, dofaston, all the drugs, and the oocytes are good and they are getting pregnancies. So checking the progesterone for oocyte quality has not been the status. It is usually done for fresh or frozen embryo transfer. This is the use. Another use is if at all you are going to check the P4 and it is 1 on the day, and the next day you've given a trigger, the previous patient had a empty follicle syndrome, and the next day you wanted to check whether the trigger has acted or not, then doing a baseline progesterone, and next day if you check a progesterone, you will be able to see the increase in progesterone telling us that the value is the trigger has acted. Because if you want to check LH, it has to be done exactly in 10 to 12 hours after your trigger. Many a times patient might not be coming at the same time. So if you want to take a random check, progesterone doesn't vary that much. So you can check the progesterone post trigger and compare with the pre-trigger value and tell that the trigger has acted or not. This is the
Just a
use of
couple,
progesterone. Yeah, you can
just a
add on.
couple of points. SNP is the level of progesterone on the day of trigger only has a value if you are contemplating a fresh embryo transfer. There is no role for frozen embryo transfer. Why are we doing it in fresh embryo transfers? That is to ensure that your LH surge has not occurred, progesterone elevation has not occurred. Because if the progesterone elevation has occurred, there is going to be a disassociation between the endometrial cycle and the oocyte cycle. Only if the progesterone is less than 1.5, ideally 1, is when your LH surge and your progesteronization has not occurred, and you can do a fresh embryo transfer. So there are, as I mentioned during the talk, there are two schools of thought that since the number of follicles are more in a hyperresponders, some centers have raised their threshold to progesterone 2 for doing a fresh embryo transfer in slightly hyperresponders, but we would not do it in any woman who is having a hyperresponse. In normal responders should be 1.5, and in poor responders, people keep the cutoff from 1 to 1.2. However, if you are attached to a center or if your center is doing a freeze all cycles, then there is no role of estimating serum progesterone on the day of oocyte triggering. I hope I answered that.
Yes, I think they would have been clear.
In long agonist cycle, do we go with gonadotropins more than 450 units?
No use. More than 450 does not really work. Only recommendation that I would use is one, use gonadotropins of standard company. Don't jump to any new company. Anytime you want to use of a new company, first use it in 10 to 15 cycles of OI or IUI. If you're getting significantly better response, only then consider in IVF. Otherwise, in IVF, consider sticking to those standard 3, 4, 5 brands. What's it, Dr. Aruna?
Yes, yes, definitely. It's very difficult to change a brand from our
Yeah,
mindset first. So
absolutely.
first for IUI and ovulation induction, then you note down the 10 patients whom you are using the new brand, check their results, wait for the results to come and then change the brand. Otherwise,
Perfect.
1 month you might have a washout.
Absolutely. Is there a way to premature
No, it's the
future?
right to prevent premature rupture after trigger 34 hours. That's the question.
Yeah, so you can use ibuprofen,
Mm.
and that is shown to prevent a premature rupture. But usually we don't see a premature rupture in especially 34 hours. But in case you are suspecting or had a previous cycle, then you can consider using ibuprofen. Trigger
Sir,
criteria in low ovarian reserve. Anita, I need more details. What do you mean by that? And what brands of gonadotropin? Sorry, I would not be able to say on an open platform, but only hint that I can give is the standard 4, 5 brands. Please use that, or I can just share my mobile number out here. You can just WhatsApp me, and I would say since this is a open platform, also streaming on YouTube, I would not be able to. So it is bad that I'm endorsing any particular brand. I don't have any favorites. It is just that these are the brands which I have used, and uh, I like it. For giving a simple example, I use the Samsung, this is the Fold 7. I do use iPhone, but I'm comfortable with Samsung. It's not that iPhone is not good. So yeah.
Yes. So well explained in a very nice way without affecting anybody. Yes, there was a question on trigger criteria. I think they're asking whether it's a dual trigger or a double trigger or you will give only recombinant HCG or you'll give an agonist. That's what they're.
Excellent question. Excellent question. So this is something. There was a ISAR meet on. We were drafting the consensus for progesterone. Dr. Amit Patki had invited me uh, to drive the consensus. So that is where we had this discussion just last Saturday, Sunday.
Yes.
Uh, what we've seen is HCG 5000 in a lot of women. It does not cause ovulation, a trigger ovulation. It does not cause a rupture. And my experience is that post-COVID, there is something which has gone wrong. Whether the oocytes have become, the follicles have become more resistant or what, but with 5,000, just the rupture does not occur. So we went to 10,000. In 10,000, we had an excellent response. I'm talking about timed intercourse, planned relations, IUI.
Yeah.
But we had around 5% of the patients that despite giving HCG 10,000, there was no rupture. I have not given Rec HCG in these women because it becomes expensive. So then I just extrapolated that since we are using a dual trigger in our IVF cycles and we are having a better quality of oocytes, why not use the same thing in timed intercourse cycles and IUI cycles as well? And since the time we've started using HCG 10,000 with a loopride. So, one particular company, a leading company, I'll not take names, uh, has loopride as 0.5 ml, 1 milligram. So the injection going to the patient, the dose is lesser, so the pain is lesser. So I use
Yeah.
the 4 mg, 4 ml for the long agonist protocol and the 0.5 ml ampules for the triggering. Since that time, we've found ovulation to occur in almost 99.5% of the patients. And in my opinion, also the timed intercourse pregnancy rates have improved since the time we've started using a dual trigger for all our patients. Because we are these patients where you've done the timed intercourse cycle, you've given her HCG 10,000, and she's not ruptured, and she would be depressed. Doctor, the rupture has not occurred. So that entire cycle has gone wasted.
Yes.
Cost has gone. So dual trigger has prevented all those things.
Good. I think it'll be useful for many of them who have at least LUF. What we are doing in our IUI cycles are when we are calling them at 34 to 36 hours for a scan. If the follicle is not ruptured by that time, we add in agonist trigger at that time so that it also helps in the luteal phase support, though it might
Correct.
rupture on that day evening. So maybe for a patient who had luteinized unruptured follicle the previous cycle, at least we can use it, if not for all. But 10,000, definitely, yes, 10,000 is useful than 5,000. I think we should use 10,000 units regularly for a patient, and dual trigger will be useful. But that mean that all your IVF patients, you give a dual trigger? We have moved on to the two.
Everything. All my
Yes.
patients, not only IVF patients, timed intercourse, IUI, IVF, all women coming for fertility clinic get a dual trigger.
And the dual trigger agonist is always loopride or you take
I
triprodin?
I have used Lupride and I have used Decapeptyl and there is no difference. Lupride cost is lesser than Decapeptyl, so I prefer Lupride.
So in decapeptyl, but we use point 0.1, point 0.2, point 0.3, depending on the age, weight of the patient.
The problem is,
Right, how
yeah,
do you use it?
I'll tell you. The problem, see, my problem with Lupride, what I've told the industry, if you have to give 0.2 or 0.3, the girl has to take 3 injections.
Hmm.
Lupride gives us the advantage. You want to give 4 ml also, na? That 0.5 ml per mg. She's going to get only 2 ml and single injection.
Okay.
So if I'm giving a dual trigger, both the injections are going to be at the same time, not at different time. Because
Yes.
for majority of our women are working, for them to come again and again for injections. So tonight I've seen her trigger criteria is met, both the injections go at the same time.
Okay.
Always Lupride 1 ml, 1 mg, that is 0.5 ml for all patients of timed intercourse or IUI. For IVF, it is always recombinant HCG and Lupride 2 milligram given at the same time.
Good, good. We should
Very
have a
simple.
SOP and it's easier to give.
Very simple. So, in my fridge also, there are only two brands of HMG. I will not say which brands. There is only one brand of Lupride. There is only one brand of HCG. There is only one brand of RHCG. So my sister or my assistant doesn't have to call up, okay, sir, what injection I have to give to this particular woman.
So
Dr.
errors are
Karthika is
less.
asking
Yeah.
how to deal with LUF in consecutive cycles of ovulation induction. I would probably check this girl for thyroid and prolactin, one. Two, maybe give a couple of cycles of oral contraceptive pills. And three, if you've not already followed, a dual trigger for all these girls. Dr.
Yes.
Selvi Raju is asking agonist protocol only HCG. So agonist protocol, you cannot do the dual trigger. It
Yes.
has to be the HCG trigger. So in a long agonist protocol, I use long agonist protocol only for poor ovarian reserve women. I will give them recombinant HCG 2 injections, not a single injection. Follicle size at which trigger? So at what follicle size I trigger in a low ovarian reserve at IVF cycles? So I would like to have my lead follicle, my follicular cohort at 18 to 20 millimeters, especially in women with low ovarian reserve.
Okay. But I will maybe, once the paper is ready, I will let you know about this recombinant HCG dosage. We are doing HCG levels the next day after giving the HCG trigger for IVF patients for almost good number of patients. Very rarely, I could see maybe one or two patients in the whole of the unit had low HCG levels after giving just one vial of recombinant HCG, even if it is obese or thin, because I had a big doubt whether higher dosage has to be given for BMI more. But there was also some papers where if the BMI is more than 35, giving a IM injection is better than subcutaneous, because the fat is very thick, and by the time you give these injections are. So maybe for a obese patient, we should consider definitely 2 doses. But for a regular patient, I think maybe with the study report, I will tell you, you will, whatever you are using, you should be comfortable with. But we are using only HCG, one recombinant HCG dosage, and zero point 0.2 triptolylin, decapeptyl. Or otherwise, if I'm going to give Lupride, exactly 0.2 mg of Lupride,
Just a correction. Just a correction. I said 2 recombinant HCG only in the long agonist protocol.
long agonist. Okay, okay. Long
For
agonist
For
also.
antagonist protocol, because in the long agonist protocol, we are not going to be using the agonist trigger.
Yes, definitely agonist trigger. So you give two recombinant HCG for the patient.
Yes, for short antagonist protocol, it is always a single recombinant HCG
Okay, okay. Yeah, fine.
and 2 doses of
The safety
Lupride.
purpose agonist protocol, so sometimes it might not act. So yes,
What happens is that, as we know, that recombinant HCG has a potency of 6,500 international units.
yeah, it's not
I want to
10,000.
give them 10,000.
Yes,
So my best bet is to give 2 doses of recombinant HCG in long agonist protocol instead of a single dose, because as it is long agonist protocol, I'm going to be using in a woman with poor ovarian reserve.
sure,
And
sure.
in this women, by giving a single HCG, recommended HCG, I don't want to have a lesser chances of oocyte conversion from M1 to M2.
Good, good. Well understood.
Yes,
Yes. So nice, very interactive session. I think the audience also had asked so many questions and they're all very active. So
absolutely. I think it was a great session.
yeah, very nice. I think poor ovarian reserve is a long term. It's not going to end, and the next generation is going to have even more difficult time.
Absolutely.
So I think more newer drugs and more newer things will evolve, and nice to have. And after the last X-ray, we also started using GCSF for low ovarian response patients. Uh, 2 months before, while giving androgen and DHEA, we gave GCSF monthly once, one dosage. There was a study which is showing, we have not done a study and completed it, but it is also useful. The last one drug which we can add on for lower ovarian reserve,
Give
GCSF.
all masala.
Yes.
Whatever works.
Yeah,
Yeah. Achha, there's one
nice.
last question. Day 5 stimulation, severe PCO, lead follicle 10 to 12 millimeters, E to 2600. Uh, Now, this is something, this is very interesting question. Dr. Arun, I want you to answer this
Yes,
first, then I would take this.
yes,
Though
yes,
this
please.
is strictly, this is not in the purview of today's talk. We are talking
But
about
you
low
can
ovarian
answer,
reserve.
kindly answer. Yeah.
Yeah. So you first, ladies first, then I'll take
Oh,
it.
okay. So if it is more than 2600 on day S5 of stimulation, that is, I think it is a stimulation fifth day, because the estrogen levels are higher, we will start antagonist for this patient, because the E2 levels being sustained more than 600 to 800 for a particular time, the LS surge starts even when the follicle is less. So if you monitored it well ahead, maybe you should have started even Monday before is my suggestion. So this patient is having a big cohort, so surely to start antagonist early.
Perfect. So exactly my thoughts. Only one point I will add. In all women, not only PCO, but in a poor ovarian response or even normal response as well, don't look at the only the lead follicle. There are the other smaller follicles also who are releasing E2. And that is also going to help, that is also going to contribute to causing the LH surge. So what our common mind is, is that we only see at the lead follicles, only two follicles, but we are not calculating the contribution from the smaller fellows as well. So just one point. Thank you
Yes.
so much, everybody,
Thank you
for
for your
joining in such
participation.
large numbers. Thank you,
Yes.
Dr. Aruna, for calling
Thanks a
me.
lot. Thanks a lot. Thanks
I
a lot
hope
for
I didn't. I
calling.
hope I didn't bore a lot.
It was, I think the audience should tell it was very interesting, and we can talk for a day on ovarian reserve, because somehow we want these patients to conceive. I think,
Absolutely.
thank you for this session. We should thank you from Foxy Society also. Looking forward for in-person participation sometime soon.
Definitely, definitely, for sure. Even I'm looking.
Yes.
Sadly, I could not make it this time, but next time definitely.
Yes. Thank you for all the participants. Do participate in our ET workshop this Saturday and also at the conference. See you all soon. Thank
Best
you.
of luck, best of luck, Dr. Aruna, for this, and thank you so much for having me here.
Thank you.
Thank
Thank you.
you, sir.
Thank you. Bye.